An interesting thing is that there is so much inappropriate prescribing of medications. If we can just look into that, we'll probably save at least hundreds of thousands of dollars in Newfoundland. So there are studies that have very effectively decreased the amount of medication by about 50% on people and elderly people without any adverse effects. Those medications were either not needed or they were just put on by somebody and then just left there because there were no reviews. Here is another data this is from the CAI, Canada Health Information System. So we look at it. There is a medication that is called, there's a medication criteria you probably would know, Beers criteria, that groups into that we should never use or we should use in really very specific circumstances occasionally. So this is the high-risk Beers criteria, and we can see that about 20 to 25%, and this has been steady. This CAI did not have data from Newfoundland, but these provinces contributed to the data. So 20 to 25% of those medications are from the group, which in fact should never be prescribed to the elderly. And this is something, like I was talking to the community referral nurse, Brenda was there, and they sent me a referral. Just looking at the referral, I saw that the person was on 2 medications from that group. So, like, first thing I'll be doing is basically trying to get that patient off that medication. So delirium, Roger has spoken about delirium quite a bit. So I'm going to just have one slide here that delirium is associated with mortality, increased length of stay, and increased institutionalization. And the problem we see is what Roger spoke out. I completely agree with him. I had that idea when I was working at Western Health, that those roadblocks, that slowing of things, lack of expertise, lack of system that would quickly identify delirium and address and treat it. So anyway, the consequences of all this delay are suffering to the patient, to the family, loss of quality of life for the patient, early placement, burden to the resources, and cost to the society. So coming to the model, basically, or before I get there, what happens, the model I'm proposing, what it is likely to do, and this is just a projection slide, it's not data-based. These are transitions from home to a senior care home to a nursing home, and this is age. So people, even at the age of 60, some of them really sick ones, can start transitioning from home to a senior's home. And then as the age increases, there is a steady decline. If we can improve identification, timely recognition, and proper treatment of the 5 conditions I just talked about, what is going to happen is that this curve is going to go a little flat here, because all those people with early dementia, people with depression that is contributing to their lack of interest and loss of functioning, people with pain who cannot function because their IADLs and ADLs are getting compromised, people with not mild cognitive, but early dementia, for which we can't prescribe cholinesterase inhibitors at this time because they have to have so much fast score. So if we get them on cholinesterase inhibitors in a timely manner, those people will be able to stay at home. So the curve will shift that way, and this is an assumption. So resource utilization, there is a major, major problem there that I see, and I've seen that for again and again. Right now, this is the current situation. We have a lot going into consultant, physician, and ER. We have a lot of effort directed at what can we do about it. This part is not being looked after. If we really want to improve services to the elderly in the early stages. We want to improve the recognition of dementia. We want to improve the early recognition of depression, or we want to make sure that the pain is properly being treated. It's not going to be me. They get to me when they're really sick. It's unlikely to be Anne either. She's probably going to see the sicker population. So we really have to change it around. We have to make this section really strong. We have to give them resources, give them training, education, and also make sure that they are doing the job properly. So the process would be, so we start with a multidisciplinary approach and get the professionals who are interested in it, who have a motivation to do it. We create a team at a province-wide level, or if we want to start here at this level. And we put together baseline measures, which I have already made a list of, and I know for depression, delirium, dementia, all those, I do have a list of measures. And we again, I know I think at least one person from the government is here. It's, over the 7 years, I really have seen they run out, they go for MCAP of documents, they go for pieces, they go for all those documents, and I don't know how much government pays for those, but those are basically scales put together by some organization that got it patented, and then basically people are buying from those. But we can put those scales together. I know that there are plenty of expertise within the province that can put those resources together. So we get the measures together, we offer education, we provide a toolkit, and we offer skill training. Again, this has not to be face-to-face. Most of this can be provided through internet or through a video system. So at the baseline, we get the data, we offer training, and then we do a follow-up. Follow-up can be 6 months, a year, depending upon what we are measuring. So that will give us some output in terms of how our interventions have worked or have not worked, and we modify them accordingly, and we go back and change the education and the skill training accordingly. So this system will automatically, it may take 2 years to fine-tune it, but once we have it in place, an example would be, for example, Bruce Hollett and I work on the same team on East 2A. I think every patient we discharge goes out, leaves with 20% at least less medication. We can simply start monitoring it, that if we just follow a certain protocol, can we really cut down on the medication or not? It's not going to cost much to do that. So we put those things together, we monitor, we get the data, we use the data to improve to fine-tune our technology, our technique, and then we develop a system out of it. At the same time, I do not see, I know Roger is very keen about it, he told me, Anne is very keen about it, that we need to improve how we are training people. These are the people who will be in the community 5 years, 10 years down the road. Many of us may be at the tail end of our careers 20 years down the road. So if we are not training those residents or medical students who are coming in and not offering them that education, they will have to go through this again. So we, instead of doing this here, that we would need to do for the GPs, social workers, nurses now, we need to get it at the graduate level. So that's basically, that concludes my talk.